Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 173 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, a month ago your hospital implemented an automatic substitution policy to administer IV piperacillin, tazobactam 3.375 grams every 8 hours infused over 4 hours instead of 4.5 grams every 8 hours infused over 30 minutes. So my question to you is, which of the following changes should be expected when tracking antibiotic utilization? A. Decrease in defined daily doses, abbreviated as DDDs, per 1,000 patient days, or B. Increase in defined daily dose DDDs per 1,000 patient days, or C. Decrease in days of therapy, abbreviated as DOTs, per 1,000 patient days, or should it be D. Increase in days of therapy DOTs per 1,000 patient days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Decrease in defined daily doses, abbreviated as DDDs, per 1,000 patient days. The days of therapy, DOTs, would be unchanged by implementation of a strategy that utilizes fewer grams per day of piperacillin, tazobactam. The DOT per 1,000 patient days would be affected if a different number of patients received piperacillin, tazobactam, or the patients received a different duration of therapy. The days of therapy, DOTs, would be unchanged by implementation of this extended infusion strategy, which utilizes fewer grams per day of piperacillin, tazobactam for a patient. The defined daily dose, DDD, is calculated using the number of grams of an antibiotic. This extended infusion strategy would decrease the total grams of piperacillin, tazobactam utilized per day for a patient, which would decrease, not increase, the DDD per 1,000 patient days. The defined daily dose DDD is calculated using the number of grams of an antibiotic. Therefore, implementation of this extended infusion policy that results in a decrease in the total grams used per day for a patient will decrease the DDD per 1,000 patient days. Please advance to the next question. And the next question reads, which of the following types of data would be used to most accurately calculate antibiotic days of therapy, DOTs? Would it be A. Patient discharge records, or B. Pharmacy purchasing records, or C. Pharmacy antibiotic orders, or would it be D. Medication administration records? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Medication administration records. The Infectious Disease Society of America and Centers for Disease Control and Prevention recommend the use of medication administration records when tracking antibiotic utilization, i.e., DOTs, because it is the most accurate method. The use of pharmacy antibiotic orders is not the recommended method for calculating DOTs because it may not be accurate. Orders do not guarantee that the patient received the antibiotic. The use of pharmacy purchasing data is not the recommended method for calculating DOTs because it probably is inaccurate. The use of patient discharge records is not considered the most accurate method for calculating DOTs. Please proceed to the next question. And the next question reads, which of the following is an appropriate method of evaluating risk-stratified antibiotic utilization? Is it A. Comparing defined daily doses DDDs per 1,000 patient days for patients discharged with ICD-10 diagnosis codes for pneumonia among similar hospitals, or B. Comparing annual days of therapy DOTs for patients in the medical intensive care unit at your hospital over the past 5 years, or C. Comparing defined daily dose DDDs for patients admitted to neurosurgical services among similar hospitals, or is it D. Comparing days of therapy DOTs for patients on medical floors among similar hospitals? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Comparing defined daily doses DDDs per 1,000 patient days for patients discharged with ICD-10 diagnosis codes for pneumonia among similar hospitals. Answer A is a correct method for risk-stratified comparison because evaluating risk-stratified utilization data involves comparing standardized antibiotic utilization among similar types of patients, i.e., on specific wards with similar diagnoses. However, data needs to be standardized per 1,000 patient days to be useful, as the wards at different hospitals likely have different number of admissions. Evaluating risk-stratified utilization data involves comparing standardized antibiotic utilization among similar types of patients, i.e., on specific wards with similar diagnoses. Comparing DDDs without standardization based on 1,000 patient days would not be appropriate because the census probably is different at other hospitals, making it difficult to make comparisons. Please progress to the next question. And the next question reads, which of the following would you consider to be a Centers for Disease Control and Prevention (CDC) core element for antimicrobial stewardship in acute care hospitals? Would it be A. implementation, or B. responsibility, or C. tracking, or would it be D. responsibility? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. tracking, and I will tell you why. The CDC core elements for acute care hospitals are accountability, leadership, action, drug expertise, tracking, reporting, and education. Please advance to the next question. And the next question reads, which of the following is the minimum number of isolates recommended by the Clinical Laboratory Standards Institute, abbreviated as CLSI, for inclusion of an organism on an annual antibiogram? Is it A. 100, or B. 50, or C. 30, or is it D. 25? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, 30. And I will tell you the reason why this is so. The CLSI M39 document provides recommendations for composing an antibiogram. 30 isolates is the minimum number recommended for inclusion of an organism on an annual antibiogram. Please proceed to the next question. And the next question reads, which of the following isolates does the Clinical Laboratory Standards Institute (CLSI) recommend including when preparing an annual antibiogram? Is it A, first isolate per patient per source, or B, first isolate per patient per year, or C, first isolate per patient per month, or is it D, first isolate per patient per admission? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B, first isolate per patient per year. The CLSI M39 document recommends including the first isolate per patient per year when composing an antibiogram. However, evaluating isolates by specific sources might be helpful for specific purposes, such as determining resistance rates for urinary tract infection and determining appropriate therapy. Please advance to the next question. And the next question reads, which of the following statements about requirements for antimicrobial stewardship in acute care hospitals is correct? Is it A, the Leapfrog Group requires acute care hospitals to meet the Joint Commission, abbreviated as TJC accreditation requirements pertaining to antimicrobial stewardship, or B, the Joint Commission requires the CDC Antimicrobial Stewardship core elements for accreditation of acute care hospitals, or C, the CDC requires submission of antibiotic utilization data to the National Healthcare Safety Network, abbreviated as NHSN Antimicrobial Use and Antimicrobial Resistance, abbreviated as AUR database, or is it D, the Centers for Medicare and Medicaid Services (CMS) requires hospitals to implement a stewardship program as a condition of participation? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. The Joint Commission requires the CDC Antimicrobial Stewardship core elements for accreditation of acute care hospitals. The Leapfrog Group is a patient advocacy group that does not require fulfillment of TJC accreditation requirements pertaining to antimicrobial stewardship in acute care hospitals. The Joint Commission requires the CDC Antimicrobial Stewardship core elements for accreditation of acute care hospitals. CMS currently does not require hospitals to have stewardship programs as a condition of participation. Tracking and benchmarking antibiotic utilization data for submission to the NHSN AUR database currently is voluntary. Please progress to the next question. And the next question reads, which of the following is an antimicrobial stewardship activity that is strongly recommended in the IDSA guidelines? Is it A, provide didactic antibiotic stewardship education to prescribers, or B, assess for beta-lactam allergies, or C, implement institutional clinical practice guidelines, or is it D, conduct pharmacokinetic monitoring of aminoglycosides? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Conduct pharmacokinetic monitoring of aminoglycosides. The IDSA/SHEA guidelines strongly recommend conducting pharmacokinetic monitoring of aminoglycosides as an antimicrobial stewardship activity. The IDSA/SHEA guidelines recommend implementation of institutional clinical practice guidelines, but the strength of recommendation is weak. The IDSA/SHEA guidelines list the level of evidence for routine assessment of beta-lactam allergies as weak. The IDSA/SHEA guidelines list the level of evidence for didactic education as weak. Please advance to the next question. And the next question reads, which of the following is not required to be reported to the CDC and NHSN? Is it A. multi-drug-resistant Pseudomonas, or B. hospital-onset methicillin-resistant Staphylococcus aureus, or C. hospital-onset Clostridioides difficile infection, or is it D. catheter-associated urinary tract infections? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. multi-drug-resistant Pseudomonas. The CDC/NHSN does not require reporting of MDR Pseudomonas infection, unless it is associated with a urinary catheter or central line. The CDC/NHSN requires reporting of hospital-onset methicillin-resistant Staphylococcus aureus. The CDC/NHSN requires reporting of hospital-acquired Clostridioides difficile infection. The CDC/NHSN requires reporting of catheter-associated urinary tract infections. Please proceed to the next question. And the next question reads, which of the following infection prevention and antibiotic stewardship practices are associated with a reduction in recurrent Clostridioides difficile, difficile infection? Are they A. use of alcohol-based hand sanitizer, decreasing ceftriaxone utilization, and use of fecal material transplantation, or B. use of alcohol-based hand sanitizer, contact precautions, and use of fidaxomicin therapy, or C. hand hygiene, decreasing clindamycin utilization, and use of bezlotoxumab therapy, or are they D. contact precautions, hand hygiene, and use of vancomycin therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. hand hygiene, decreasing clindamycin utilization, and use of bezlotoxumab therapy. Hand hygiene, decreasing utilization of high-risk antibiotics, and the use of bezlotoxumab, a human monoclonal antibody product that targets Clostridioides difficile toxin B, have been associated with reductions in recurrence of Clostridioides difficile infection. Contact precautions and hand hygiene are infection prevention measures that reduce the incidence of Clostridioides difficile infection, but vancomycin therapy has not been shown to reduce Clostridioides difficile recurrence rate. Alcohol-based hand sanitizers should not be used when treating patients with Clostridioides difficile because these products are ineffective against spores and their use increases the risk for relapse or reinfection. Contact precautions and fidaxomicin therapy have been associated with reductions in recurrent Clostridioides difficile infection. Decreasing the use of high-risk antibiotics and fecal material transplantation have been associated with reductions in recurrent Clostridioides difficile infection. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 174.